Everyone knows prevention is the cheapest and best way to address homelessness.
So then why don't communities ever use this strategy?
Well, I'm Josh. I help cities address homelessness, and I'm going to tell you why governments don't do prevention.
And I'm KK. I'm the founder of Care Beyond the Boulevard, a street medicine team. And I'm going to talk about why that drives us nuts. This is Untangling Knots, where we break down complicated topics about homelessness from two different perspectives. Today is episode 2, Reaction versus Prevention, comparing the costs of homelessness. Now let's untangle some knots together.
The views and opinions expressed on this podcast do not necessarily reflect those of the employers or organizations that we represent. Thank you.
Absolutely. So when we talk about homelessness, we oftentimes see that municipalities, agencies are reacting to a situation. Many times it's reacting to the community's reaction, right?
Yeah,
like the community calls and they call 211 or 911 or whoever it is, and they complain about an encampment, about something going on in their area. And so the city then reacts, or municipalities react to those calls because their constituents are in there, the people who vote for them are in there, and they have to do something.
Yeah, this is, and I think homelessness is one of the most glaring, it's an amazing example of where prevention is the most effective. And at the same time, there has been virtually no pivot towards that. Reacting, it seems to be the way that cities really want to address homelessness. And it's shocking because it's at least 10 times more expensive. Let's break down the most basic element of this. Let's take this is a situation my mom was in when I was quite young. She was divorced. She had 4 children. She had a high school education. It's going to be about it. She was able to maintain her housing through help from friends and family. If she lost her housing, let's talk about this cost. So rent, let's say rent back then was $500, whatever it was. This is the 80s. $500 kept her housed. If she lost her housing, not only do you have that eviction on your record, that's a cost, you have to pay what you owe in terms of whatever that property owner is telling you you owe. That goes on top of wherever you're going to go next. So first and last month's rent, probably want you to pay ahead of time because you got evicted from this other place, you owe them money. So a $500 prevention turns into a $3,000 to $4,000 cost. This plays itself out at every level of homelessness. But the system is designed this way. It is not designed around prevention. And prevention, it is a shift in worldview at a level of changing to the metric system. The cities just don't consider this. Think about how cities do budgets. They decide what they're going to have to spend a year in advance. And there's almost no wiggle room. All of it, every dollar has a name. So prevention in some way involves setting aside a specific amount of money, having a designated program, when in reality, you're going to have all that money already spent and accounted for, reacting to what's already happening in your city. This is how it works everywhere. The other frustrating part of this, funding from the philanthropic community is really geared the same way, reacting to a situation. And it's really simple. You can't see the effects or the impact of prevention. You can't measure it.
Right.
You can't get on a podium and tote it. You have to, as a politician, you are looking for very visual victories. Prevention does not provide you those. So the entire system is not on every level, political level, funding level, how we even think and strategize and problem solve. Prevention is almost never considered in this.
So one of the biggest things that you can see is cold weather. Right?
Oh, cold weather is a great example.
So several years ago, the city came to us. This was actually before you worked for Kansas City. The city came to us and they asked us to run a cold weather shelter. The plan was terrible, frankly. They wanted us to just manage it and they were going to tell us what to do. And I said, no, because the person who was telling me what to do had no experience in homeless outreach work.
Shocking.
They wanted to put bed upon bed. They wanted to make sure that there were all of these things. And I said, no, I'm not going to do it. I will not do it. But one of the things that I told the city at that time is I said, you need to stop being reactive. You need to have a prevention strategy for cold weather, because cold weather comes every single year. It's here. The last several years have been brutal. Right? And we do now have a cold weather plan that Josh has put into place. But
I have a good team.
You do have a good team. But the problem is, it took years of reaction to get that in place.
And I think of the cost of the reaction. Yeah. Even the institution of a cold weather shelter was born out of reaction.
Yeah.
Now, look, it's important, especially folks who are obsessed with ending homelessness the way that we are. It is important to take advantage of reaction whenever we can, especially if we can use it to install preventative measures or at least long-term solutions around cold weather, which we were able to do. But the reason the conversation was happening was simply a reaction.
Absolutely.
It wasn't considered until the bad thing happened. And if I could boil down working in, I have conversations with many cities across the country about homelessness. And if I could boil the conversations down, this happens every time. I'm going to point out a piece of dog poop on the sidewalk. See, it's right there. And the city's going to go, okay, I'm going to go ahead and step in it. And you're sitting there going, you don't need to. I'm telling you where it is. It is right there. They are so locked into however it is they're doing, whether it's a political or this is our system, they're going to, and they are committed to stepping in it. So then you have to spend time cleaning the shoe, cleaning the sidewalk, all the accoutrement, translate that to whatever. So you have added cost, added time. Prevention is a worldview. It is not anything less than that. If you can't shift that worldview, it's not going to happen. And worldview, man, you are shifting it little by little, 2% at a time, 1% at a time. And at some point, someone goes, oh, I see that dog poop. They're still going to step in it. That's that 1% that we're moving. The entirety of cold weather shelter was that. And what's interesting is, and this happens everywhere, a municipality goes to the expert. You as an expert say, do it this other way. And what did they do? They stepped right in it. And it was extraordinarily costly. Now, it bore out the necessity for, and every municipality needs to hire someone to be the expert on homelessness. Whether they respect that expert is going to be tentative, and it's going to wax and wane for sure. But it's just like with anything. It's just a political issue as much as it is anything. Yes. You need to hire someone to do this. So at least you have someone in your sphere pointing on the sidewalk not to step there.
So I think one of the things that we have to bring up, though, right, when we're talking about reaction versus prevention, right now, where we are in the country with homelessness, you kind of have to invest in both right now, because one of the things that we know is homelessness is increasing. According to the National Alliance to End Homelessness, the point in time count from 23 to 24 saw an 18% rise in homelessness, right? So
that's massive.
In 1 year, right?
Well, the point in time count is the annual count. If you Google how many homeless are in America, that number that pops up, it comes from something called the point in time count.
Where they go out the coldest day in January and count the people who are living on the street.
We will do a
podcast count
on this count, but it's the number we have, and what she's saying is there's an 18% jump.
Right, in 1 year, right? In 1 year. So when you're talking about prevention and reaction, there has to be a tad bit of support for reaction. So
Absolutely.
Don't get us wrong. We're not saying, oh, don't react. You have to, because you already have hundreds of thousands of people sleeping on the streets in the United States.
Yes.
So prevention is going to help that 18% not come to the streets. Whereas that the money put towards reaction is going to then help provide services to the people who are already on the streets.
That's right.
So I think that it's really important to note that we're not saying, oh, don't react, but you have got to start somewhere with prevention and supportive services that work towards prevention of the homelessness and ending homelessness.
Yes, and what's there's a trajectory in homelessness. If you are homeless as a kid, you are 46 times more likely to be homeless as an adult. Prevention at youth homelessness absolutely and unequivocally prevents adult homelessness.
Yep.
And among chronically homeless, these are folks that you see staying in encampments. 80% of the folks that you see in encampment were homeless as a kid. Chaos when they're little. Youth homelessness causes a lifetime of damage. This is the easiest point of prevention. It is academic. It is not complicated, and it's still not done. We know the answer, and we still don't do it.
So that leads me to a really good thought. That communities can end homelessness
Yes.
by investing in services. Now, I come from the healthcare lens, so I'm going to talk about healthcare. But what we know is that if you invest in healthcare for those who are experiencing homelessness with wraparound services, you're going to essentially end homelessness. And I'm going to use a subpopulation. So when we're talking about homelessness, there's always like subpopulations, youth, veterans, LGBTQ+. There are different subpopulations. Now, we don't focus on any subpopulation. We take care of everybody and anybody, which is pretty much any street medicine team in the United States, right? But when we talk about veteran homelessness, right? The veteran homelessness has been almost eradicated. I think it's at 8% right
Oh, yeah.
now.
It's incredible.
It's at 8%. So veteran homelessness used to be the largest subpopulation of people who were living outside. Now we have it down to 8%. But if you look at that, they took their programs and focused on a subpopulation and the services that they need to end homelessness. A lot of those services include healthcare resources.
Yes.
So if it can work for veterans, why can't it work for every other subpopulation or population of those who are experiencing homelessness? But what has to happen is we have to pour resources in to provide those services.
It's a heavy cost up front. And that's the other thing about reaction. You brought up such a good point. That upfront cost seems high, but when you are reducing cost over time, it is invisible. You don't get credit for that.
Well, that's exactly what we do in street medicine and street medicine teams all over the United States. So when we're going out and looking for funding, because our agency doesn't bill for services, so we rely heavily on grant funding and private donations. And one of the things that we have a really hard time showing is cost savings.
Yes.
Because I can't say to a hospital, well, I can say I do, but I don't get much of a reaction. But to say to them, okay, well, we took 25 of your patients last year and put them in our medical respite for a total of 800 nights, right? That's a cost savings to the hospitals.
How much? 6 figures?
Oh, yeah. Or more.
Yeah.
But the problem is that large entities, cities, health systems, their bottom line is the bottom line. How much money did that bring in? Street medicine does not generally bring in money for hospitals. It doesn't bring in money for cities. But what we do is a cost savings.
Yeah, cost
and
savings
that's where
is
it's
a line of
really
revenue.
difficult, right? Because what we do in street medicine is we work to improve the health outcomes of people who are living on the streets. And in turn, we are preventing downstream acute care utilization. But it's hard to measure that.
Yes.
Right? Particularly here in Kansas City and in many large cities, you have multiple healthcare organizations, right? We have how many, I think we have like 12 hospital systems in Kansas City. We are not unlike San Francisco and New York, where there are multiple health systems and really pretty close proximity to each other. So I can say, okay, well, so Josh Henges, we see him on the streets and we take care of him. How many times has he been in your hospital or your hospital, right? And then after he like works with us on the streets, does he decrease utilization? Well, they're going to look just at their utilization.
They don't talk to each other.
They don't talk to each other. So it's really difficult for street medicine teams to show their value. But what we know is by decreasing downstream healthcare utilization, we're going to help the systems in general.
Yeah, and what's interesting is, even with preventive, with the best, clearest information that your intervention is saving money, there's virtually no reaction to support it. And I know it's hard to believe. It is hard for people to understand it. So whenever I do any kind of engagement with the general public when we're talking about homelessness, this comes up. It is a logical position. If you save money, take that savings, turn it into a revenue stream, and fund the other thing. It requires a type of measurement that organizations simply don't do. Like take 911 system. Addressing homelessness saves your 911 system considerably. Homeless folks cause a lot of 911 calls to happen. Most often, it is a healthcare situation that needs to be addressed, whether it's behavioral health or physical condition. Those costs are not measured when they're not happening. And think about the budget process. Every department, doesn't matter what city you're in, everyone's asking for the most money. The most. Whatever cost savings you might have, they already have a thing they want to spend that money on.
Right.
If it's another person, if it's a machine, whatever it is. So like the system as it is doesn't really produce prevention as a viable option, not in funding, not in strategic planning. It does for us, and certainly the general public sees this as a very logical this to that. But the way systems are designed, funding, political, it isn't measured, it isn't considered, but it is real. And the only way prevention can have the impact that we know it can is everyone has to talk to each other. Everyone has to be on the same system. Everyone has to be measuring things the exact same way. And that is where the lift is. It is not the logical, you're not going to persuade someone with rhetoric and logic. They get it. You have to completely redesign the policies and procedures of massive organizations and institutions to get this done. That's what it means to address homelessness, and that's what's really what it means to get prevention as a viable option.
Well, I think one of the things that happens, right, this is kind of the thing that we see, is that you keep doing the same thing and expecting a different result.
Yeah, but they get money for it.
I know. And funders, right, this municipalities, they're funding the same things and expect a different result. And so if we don't change overall the way we're doing things as a municipality, I'm not talking about just Kansas City, I'm talking about every city. If you don't change the way you're doing things, you're not going to change the outcome.
Yes.
Right? And so part of that prevention is taking a look at what you're pouring resources into, how those resources are working, and rethinking where those funding dollars are going, rethinking where that support, and we talk about dollars because I work in the nonprofit world, and so it's always at the forefront. I've got to pay my bills, I've got to pay my staff, but this is with everything. This is support. This is donations. This is support for agencies that are doing the work.
Yep.
And this is not continuing to do the same thing over and over and wondering why, and I brought this up before, Kansas City leads the nation in chronic homelessness of people who are sleeping outside. 96% of our people sleeping outside have been out there for more than a year.
So like what she's saying is, if you become homeless in Kansas City, you are going to do it outside. So you could become homeless, stay in a shelter, stay in a transitional living program. You're still homeless, but you're sheltered. Kansas City leads the nation in chronic, unsheltered homelessness. If we had the same population as Los Angeles, we would have more people living outside. So obviously this is demography based. But Kansas City's got a lot of room for improvement.
Right. And but we keep hearing the same things happening. Agencies are not changing the way they deliver services.
And they're not going to.
Because they continue to get funding.
Well, that's how the funding system works. So like the idea that a nonprofit would decide to not do what their nonprofit mission is, and then all of a sudden decide to start and help solve a communal goal is never going to happen the way the nonprofit system works. The nonprofit system around homelessness is a grassroots model. Everyone, come on in, we'll figure out where you fit. If you want to solve homelessness, it has to be top down. There has to be a communal goal. That a goal needs to be agreed on and then pursued. When you do that, you actually create the infrastructure to measure progress. If it's a grassroots system, there's almost no measurement. There's almost no data sharing. And where there is data sharing, it's not to help the city solve the problem. It's to give the federal government information. That is not near enough information. It's not near enough folks. Think about even on the departmental level at a city. The Public Works Department does not have the same goals that we do in Unhoused Solutions. 911 doesn't have the same goals. So when we're talking about prevention, they are everyone, to include nonprofits. They're only thinking about it in the terms of their own organization or their own work. This is how it works in a grassroots system. In the city, what a municipality does is it plugs itself into that system. That system is not designed to actually solve homelessness at all. So what municipalities have to do is they have to lead in this effort of creating a top-down model of a community goal first, and then assessing and deciding which nonprofits can help you hit that community goal. Cities don't know how to do it.
Right.
They don't know how
to set those goals.
They don't even know what it means to end homelessness.
Right.
Most cities, if this is why it's so important to hire someone who knows what they're doing. Now, picking that person is going to be tricky.
Right.
It's tough. Most folks in this field don't know what it means to actually end homelessness. But that's our goal here. We want people to understand this. We know we can get them there.
Absolutely. Absolutely. Do you know how most people get out of homelessness?
Get out?
Yeah.
Money and people.
Money and people?
That's how homelessness has two ingredients in America. You run out of money and you run out of people, and it happens at the same time.
Absolutely.
It's the same thing of getting out of homelessness. It's money and people.
Well, when you're looking at people who are experiencing homelessness, the average age of death is around 50 years old.
Oh, yeah.
And the average age of death of people who are housed are 78, right? So
it's quite a range.
Waiting for people to die outside, it doesn't seem like a very good option to me.
Just so some municipalities it is.
Well, I know, but
I don't about them all the time.
I don't think it's a very good idea. I think that if you utilize resources, you can increase their health. We know that the causes of death of people who are experiencing homelessness are much the same of those of us who are housed. Heart, lungs.
Yes.
We also have a higher number of HIV, hepatitis, substance use disorder, mental illness. There's a higher percentage as opposed to those who are who are not homeless. But the problem is that someone with high blood pressure who lives on the street is going to have more complications related to that high blood pressure when they're living on the streets. Diet is poorly controlled. Like, they have no control over their diet. They're eating whatever people are serving, understandably, because you've got to eat, right? But there's no like low sodium at the soup kitchen, right? It just doesn't happen. Their medications frequently get lost. You know, we can talk about camp sweeps. We already did, but when people get their camp swept, their medications go with it, right? That's not their priority. So if we can work on prevention, right, we can also increase the longevity of these human beings. Like, that's the thing. When we're talking about people who are experiencing homelessness, we're talking about human lives. Yeah.
Most people don't see it this way. They simply don't.
Yeah, I know, but it's my personal opinion that they should.
Yeah, I agree.
I mean, yeah.
I think to a city, municipalities, I believe that they ought to see it this way. But even if you don't care the way that I think that we care, you can at least see a 50-year-old being a productive member of society if they are not homeless.
Right.
That is a tax base. That is a law-abiding. That's a renter. That's someone who buys from shops. It's what you want out of a municipality. So even if you're heartless, even if you're Corella DeVille, you can see the value in someone being alive longer than 50 in your city.
50 is not old.
Not
Speaking
old.
from someone who's over 50. 50 is not old.
I'm 10 years from being old, and if I was unsheltered, I'd be on death's door.
I would have been done already.
Yes.
Right? So I think that that's a very important point about that age, right? That age and the gap in death, that 50 is still productive members of society.
Oh, absolutely.
And when you're living outside, it is very difficult to be a productive member of society because of all of the barriers that you encounter. So I think that if we work on that prevention, right? That prevention, the health prevention, the preventing other people from becoming homeless, then we're going to increase the health of our communities.
Yeah, it's the difference between providing blood pressure medication and waiting for a heart attack.
Right.
That is what we're.
And that's exactly what happens.
Of course.
Yeah.
We love paying for heart surgery.
Yeah.
We hate paying for Lipitor. whatever it is, whatever it is, the most prescribed medication on planet Earth. All right, we're going to pivot from here to questions from the community. We love these. This is my favorite part about it. It's the Ask the Expert section.
Absolutely.
KK's an expert, so let's
So is John.
let's see what we got.
Speaking in the medical world, there are some preventative measures. Do any of them at all hit your world of street medicine? Are there any medical preventative measures for the homeless?
This is such a good question. You can keep it there.
Wow. So,
Prevention in medicine is what you're going for.
right.
In the same way, so like there's just this amazing parallel to how difficult prevention is in homelessness and how we don't do it with the because you can't.
So, okay, that's a really convoluted question because we have different levels of prevention, right? So we have the prevention that people think about, like mammograms and colonoscopies. We think about those preventative measures. And so pap smears, when I think about those for my patient population, they don't get done. I have women on the streets who are dying of preventative cancers. I have people dying on the streets of colon cancer because they're not getting their colonoscopies done. So here's the thing. For those of us who have had our colonoscopies, the prep is horrible, right? And you get raging diarrhea, and it's not pleasant. So for people who are living outside and they need to have a colonoscopy, their options are have their prep, go poop in the woods over and over again, or not have their colonoscopy. Yeah. Guess what? They're not going to have their colonoscopy. So when we talk about prevention, we think about like those big things. But the other thing that in medicine, we look at prevention, and Josh kind of mentioned that. He was like, we'd rather pay for heart surgery than lisinopril or Lipitor, right? Giving someone blood pressure control, helping them control their blood pressure. For people who are at high risk for any type of stroke or heart attack, making sure that they have access to a statin or lipid lowering medication is also a prevention. For people who are diabetics, it is basic guidelines that they should also have lipid coverage, because we know that people who are diabetics have an increased risk of heart disease or stroke related to their poor.
But can you do it?
Yes, you can do it. You can do it.
How much harder is it?
It's exponentially harder.
It's hard to even quantify.
Right? Because here's the thing. When you're living outside, you lose your medications. It rains, things like that. And so then what happens? So let's talk about diabetics, right? Because we have a lot of diabetics on the streets, people who are on insulin. We give them one pin at a time. Pins can stay out for like, I think it's 31 days or something like that, right? And it can be at room temperature. It shouldn't be at extreme temperatures, but it can be. But people who are diabetic should have that cholesterol control as well. But sometimes they're like, I can't handle more than one medication a day. So as a provider, my choice is, do I give them the insulin or do I give them the statin? Guess what? It's going to be the insulin all day long, right? Because that is more reactive than preventative. If we can develop a relationship with people, and we'll be like, okay, let's just start with the insulin for 3 or 4 months, and then we can ease into that conversation. You're doing really well with the insulin. Can we now add something for your blood pressure? Can we now add something for your cholesterol? So there's a lot that can be done in prevention when you're talking about health for people who are experiencing homelessness. To me, blood pressure control, lipid control is much easier than doing a pap smear or a colonoscopy. So those different level of preventions, they're actually easier to manage with medications.
Great question.
Okay, question for Josh. You mentioned that Kansas City has a homeless prevention plan. Can you briefly describe that plan?
Yeah, we're not at a point where prevention is even an option right now. I would love prevention to be the sole thing that I get to do, but no, we've got to do intervention before we do prevention at this point. So if we're talking about creating prevention plans specific to a certain situation, like cold weather, for instance, we have a great plan. We have an incredible cold weather plan. It's still reactive. The prevention part is we know it's coming, we plan for it, we budget for it, we have a repeatable way that we do it. We share this information with cities across the country. They employ it's great.
Hold on,
works.
let me say something. A few years ago, there was no plan in place. When I talk about the year that they asked us to do the cold weather shelter,
Yeah.
they came to me in January.
Yeah, I know.
Right. So you're right. I want to throw that out there. Like now we have a plan that's working all year round.
Yeah.
As opposed to what we did before. Okay, sorry. Go ahead.
Yeah, and a true prevention plan, when you get to the point where you've addressed on some meaningful level chronic homelessness, that's the homelessness you see outside. Prevention is simple. You focus on families and you focus on youth. That is how you prevent homelessness. You must focus on those two things. Overwhelmingly.
For prevention.
Yeah, for prevention. 80% of funding goes to single adult men in the world of homelessness. That is almost all of the funding. Doesn't matter what city you're in. That is what it goes to. And right now, we have the highest increase in youth homelessness and the highest increase in family homelessness. So if that isn't plugged, then we're going to continue spending 80% of our money, it's probably more, on single adult men. But if you want to do true prevention, it's families and youth.
Thanks, Josh.
Yes, you got it.
So join us next time on Untangling Knots,
Knots,
where we'll continue to explore the challenging realities of homelessness without the sugarcoat.
We get real. Thanks so much for watching. We'll see you next time.
Bye.